For those of you guys that don't know me, I am a physician associate and a health educator. I live in Washington, D.C., where I work as a PA health educator, uh, where I live with my wife and children. So I was asked to speak about what it is to be a hospitalist, physician associate. You may hear the term physician assistant used interchangeably also. So I'll talk about that. So I've been a PA for a little over 20 years. Of that 20 years, about 7 has been as a hospitalist. So a hospitalist is a clinician, usually a physician associate or nurse practitioner that is responsible for patients while they're in the hospital. What may happen to you, or even me, is that we may become hospitalized due to an acute manifestation of a chronic illness like diabetes or respiratory failure or something of that nature, or even have an injury like a car accident or unfortunately a gunshot wound, which is not that uncommon here in Washington, D.C. What will happen is that you or your loved one will be hospitalized. Your primary care provider might not have privileges at the hospital where you're hospitalized. You or your loved one are hospitalized. So it's the role of the hospitalist to actually oversee that person's care while they're in the hospital until they're discharged, either to home or a nursing home. So I'll tell you about me as a PA. There are about 140,000 certified and licensed physician associates in the U.S. Of that 145,000 or 140,000, a growing percentage are being enrolled as hospitalist practitioners or specialists rather. So it's an increasingly popular specialty to go into. I will tell you as a PA, I worked very hard to become a PA. I've got an undergraduate degree in biology, and then spent 2 years as in my physician assistant training. Graduated from Howard University, and then University of Nebraska Medical Center. That's where I did my master's degree. Then I had to sit for the boards, and then I worked in outpatient for a while. But yeah, I had a lot of, considerable amount of medical knowledge within me, stored up here. As a hospitalist, I've been able to use almost all of that. Now, I work exclusively with adults. There are some hospitalists that work with children. They're in pediatric hospitals. There are some that work exclusively with the geriatric population, and they may have an association with nursing homes. But I work with adults, so that could be anyone as young as 18 to beyond. Some of my oldest patient was, they've been over 100. So I use all of the stuff that I learned in PA school, with the exception of the pediatrics, of course, in my role as a hospitalist. So I show you some of the books that I use. Here's one very good book. This is Critical Care and Hospitalist Medicine Made Ridiculously Simple by Dr. Michael Donahue and Mark T. Gladwin. So you can see this patient up here is very sick. They're a mechanical ventilator. They've got something called a BiPAP mask on. They've got IV fluids, and it's hard to see it. Yeah, so IV fluids running, and then there are all of these interesting abbreviations up here, but you don't actually know what all of these mean. So you've got to, but the doctor's trying to figure out, or the clinician is trying to figure out what's going on with the patient, and that's part of the thing that I like about the hospitalist work is that you've got to really be a good medical detective. A lot of our patients come in with what we call admissions papers, or the transfer summary. So we already know what some of their diagnoses are. So congestive heart failure, hypertension, type 2 diabetes mellitus, acute or chronic respiratory failure, maybe chronic kidney disease, maybe an infection, and they're on an antibiotic regimen. But then there's other things that happen. So you've got to be very wary and in tune to the the things that are going on with your patients. There's things that we look at called our subjective data versus objective data. So the objective data is things like your lab results. Um, so this is why you need to know a lot of chemistry. There's another good book, clinical chemistry. So you may hear these orders shouted out. If you watch any of these medical dramas like Grey's Anatomy, ER, Chicago Hope, I think there's a Code Black is another one, and they say I need a CMP, a BMP, a CBC with diff, an ABG. So they're the doctors yelling all these orders out, but that's in a book like this. So that's going to give you your chemistry panels. So a phlebotomist will come in and draw the patient's blood, and we're able to look at different objective data that kind of guides us as to where we need to what we need to do for our patients. Sometimes we've got to make adjustments in their chemistries if they have a high potassium level or something like that. Another objective data would be X-rays. So what would and this is a good book, Field Guide to the Chest X-ray. We order chest X-rays a lot because we've got a lot of patients we've got respiratory failure, especially in this during this COVID pandemic. A lot of them have superinfection with pneumonia, things like that. They may have underlying conditions like coronary obstructive pulmonary disease, asthma, and then maybe even some genetic disorders that affect the lung. But you can find out what's going on with them by means of an X-ray. Another good book I use is Clinical Medicine. So this has got a lot of pictures in it. I tend to be a right-brained type of person, so I've got to I learn very well by seeing. So if I see something awry with the patient, here's Marfan syndrome, hyperflexibility, obesity. Um, it'll help you form a diagnosis, and then your kind of clinical management of a patient. Another good book, Antibiotics for the Clinician, and the ABCs of Choosing the Right Antibacterial Agent by Alan Hauser. I use that. We've got a lot of patients with infections, and when they get something called sepsis, so it's a bacterial infection. It can be in the lungs. It can be in the urinary tract infection. We can have patients with different. What are some other intestinal infections, wound infections? So you got to know the correct antibiotics to put them on. So you have to have a very good understanding of infectious disease. Not that you're the expert, because we also have to consult with experts. So we may consult with the infectious disease specialist, maybe the cardiologist, in terms of if we need help trying to figure out what's going on with a person's heart. We may have to contact a GI specialist, so a gastroenterologist. And there's a whole array of specialists. Those are the guys that make more money than those of us that just do simple primary care. And then some patients we even have in the ICU, in the intensive care unit. So I like to do extra reading in, this is the intensive care unit manual. If a patient starts to decompensate or they get worse during their hospitalization, I've got to know when to transfer them to the ICU because it becomes what we call a higher level of acuity for this patient. So then you're talking about somebody who you really want to keep your eye on them because you don't want them to die. They may need something called pressors. That's a special class of medication to keep their blood pressure up. They may need invasive innovation or intervention, I should say. So that segues to a topic that nobody likes to talk about, end-of-life care. Some patients come into us very sick. They've got metastatic carcinoma, so the cancer that's spread throughout the entire body. Some have got various genetic disorders that are actually literally killing them, and they're not going to get any better. So we have to have a discussion sometimes with the patients, families. This person's ending they're going toward their end of life. What code status do you want to make them? Do you want to make them a do not resuscitate, maybe a modified do not resuscitate, or do you want to keep them a full code? That's where we're doing, if their heart stops, we're doing chest compressions and shocking them. All this cool stuff that you see on television. It looks really cool, but it can be very devastating to the patient. Not everybody comes back like in the movies and the TV shows, where they're got the paddles clear and you shock them, and then you get the kind of heartbeat coming back, and the person gets up and walks out the hospital. That quite often doesn't happen, especially if the person's really sick, if they have something that we call multiple morbidities. So lots of different diseases at once. Another thing at the base. Oh, let me talk about this. EKGs. So EKGs. Here's another good book I use. EKG interpretation. A lot of times we've got to order EKGs on patients. These things is 12-lead EKGs. You'll see that everybody's probably seen in the movies where you've got that little beep, 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 that kind of heartbeat thing. Well, we want to know more specifically what's going on with the heart. And the electrocardiogram will tell you that. It gives you a notice if the person had a heart attack, if they have something called STEMI, so ST segment elevation. We never like to see that. If their electrolytes are off, if a person's got too much potassium in their body, you'll see something called peaked T waves on the EKG. Another thing I like to read about is the brain X. We have a lot of patients who have had seizures, or they're on anti-seizure medication. There's things like Keppra and Lamictal. We look for those things. You got to treat them if they go into something called status epilepticus, where they're seizing nonstop. You got to give them a medication called Ativan. But I find the brain very interesting. It's what I tell families is really the software. The brain is the software, the hardware. The body is the hardware, so the heart and the kidneys and lungs and all that. But the brain is the thing that runs the whole. So if you think about how a computer works, or even this phone, the screen and the buttons and things on it is the hardware. The covering is the hardware. But if the software is broken, the phone's not going to function. So you got to know quite a bit about the brain. Not that you're the neurologist, but you've got to be able to really figure out what's going on with the patient neurologically wise. And that's it for. Oh, I'm sorry. One last thing. So at the base of everything, you have to have a very good understanding of physiology. So this is a book I love reading. This is Netter's Essential Physiology. This is Netter. Dr. Netter was an outstanding anatomical illustrator. So again, me being somebody who is visually inclined, I like a lot of nice charts and pictures. So that's what you get with letters. It explains the physiology is the functioning of the anatomy. So it's not enough to know how the heart works and where the heart is and how it's designed. You got to know how it's working. When somebody's got atrial fibrillation, what's going on there? When they've got that's it for me. I wanted to keep this brief so as not to bore anybody. But a hospitalist job it's a great job if you really want to use a lot of your medical knowledge that you learn in medical school, PA school, or nursing school. You work with a very comprehensive group of people. So your respiratory therapist, your nurses. Let's see, somebody's got. What are my thoughts on semen retention? Well, let's see. There's a number of reasons for semen retention, but not a urologist. So I don't know if that's a tongue-in-cheek question, but if somebody has that, they should go to a urologist. There's an area of the testicle called the seminiferous tubules, and those can have blockages in them. I did do a rotation with a urologist and a fertility specialist that knew much more about that than me. But for that you've got to go to a urologist, and if you're somebody who's trying to have a baby with your significant other, you may even need a fertility specialist. Do you think SR improves memory and cognition? Oh, I don't know. I haven't seen any research on that. So one of the things that we do in medicine, so there's a caveat. You try to stick to your role. So that's definitely not my role. So if you have questions pertaining to something like internal medicine or hospitalist, which is what I'm talking about now, I'd be happy to answer those questions. So if you are, so I'll tell you about the training real quick. If you want to be a physician and become a hospitalist physician, that's 4 years of undergraduate, usually garnering a degree in something like biology. Then you take your MCATs, get into medical school, and then you're welcome. This is Mr. Singh. So then after finishing medical school, you hopefully have been matched and probably do a rotation in internal medicine. That's your classic primary care medicine. So that takes 3 years. And then maybe a fellowship in intensive care medicine. So you can efficaciously cover in the ICU, and then go on to get a job as a hospitalist physician. If you're a physician assistant or associate like myself, you'll do a 4-year undergraduate degree, usually in something like biology. Some even do an allied health 4-year degree, like in nursing or something like that. And then apply to PA school, and that's 2 years. And then you would just get a job working as a hospitalist. Some hospitalist groups prefer that a hospitalist PA have at least 2 to sometimes 5 years of experience, maybe working in internal medicine or maybe something like emergency medicine, because you really have got to be a fairly quick thinker. You have to have a very good understanding of medicine within your capacity. Okay, that's it for now. I wish you all the best of success in your positive endeavors. Let's see, do you think well, let me answer this one last question. Do you think it's harder to get PA jobs in the New York area? It depends on the area of New York and what you're talking about. I'll say that PAs in New York tend to get paid higher than most places. You can make anywhere from 130 to, I've heard, as much as 180 as a physician assistant, which is really good in New York City. But also understand that, so the Bronx area. So Bronx it's one of the less expensive areas in New York. It's not as expensive as, say, downtown Manhattan, but especially if you're working in the inner city, like the hood of the Bronx. But you're still, you should have a fairly good chance of working as a PA in that area, especially if you work in one of the underserved areas. It's really needed. There's areas, if you want to work where there's not a lot of doctors with clinics. But that's it for now, guys. I'm gonna switch over to Instagram and do a live video over there. For those of you guys that are interested. But I should say, lastly, being a physician assistant or physician associate, you should be able to make between 120 to about 170,000 as a hospitalist PA. On average, you can expect to make about 130. It's one of the better paying PA jobs. And I missed, somebody asked a question here and I missed it. So that is it for now. Subscribe if you would like. There are other PA related YouTube videos out there. I think I'm probably one of the older PAs. I've been doing this for a little more than 20 years. I'm pushing the big 60 now, believe it or not. Let's see, does a hospitalist mean internal medicine? It does not, but I'll tell you that most hospitalists have a background in internal medicine. That's been my experience. The group with which I work, most of the doctors are internists, and most of us that are PAs have backgrounds in internal medicine as PAs. Okay, guys, that's it for now. I wish you guys peace. Please leave comments in some of my other YouTube uh, videos if you have if you have any questions, and I'll try to help you out as much as I can. Take care.